Okay, boys and girls, let's move on to the lymphatic system. So in this chapter, we are going to list the functions of the lymphatic system. We're going to explain how lymph forms and returns to the bloodstream. We're going to name the major cells of the lymphatic system and state their functions. We're going to name and describe the types of lymphatic tissue, and we're going to describe the structure and function of the red bone marrow, the thymus, the lymph nodes, the tonsils, and the spleen. So in the lymphatic system, we deal heavily with fluid recovery. Fluid continually filters from the blood capillaries into the tissue spaces. The blood capillaries reabsorb 85% of it. 15%, which is 2 to 4 liters per day, of the water and about half of the plasma proteins enter the lymphatic system from interstitial fluid. After being filtered, lymphatic fluid eventually returns to the blood. Immunity. Immunity happens when there's excess filtered fluid that picks up foreign cells and chemicals from the tissues. It passes through lymph nodes, where immune cells stand guard against foreign matter, and it activates a protective immune response. It functions in lipid absorption. Lacteals in the small intestine absorb dietary lipids that are not absorbed by the blood capillaries. So here's an example of how that lymphatic system wraps and follows blood supply. So here we can see the capillary bed in a tissue. We can see that we have tissue cells surrounding the capillary bed. And we can see the difference between arteries and veins, and then the lymphatic system kind of looping in and wrapping around that entire capillary bed. It maintains fluid balance, protects the body from infection and disease, and absorbs lipids from the diet. So lymph is a clear, colorless fluid and is similar to plasma, but with much less protein. Extracellular fluid is drawn into the lymphatic capillaries. So within those lymphatic vessels, terminal lymphatics lead to collecting vessels, leads to the lymphatic trunk, the collecting ducts, and then into the subclavian veins, which gets dumped back into the circulation. Lymphatic tissue, this is what happens when there's an aggregate of lymphocytes and macrophages in that tissue, and they populate many organs in the body. Lymphatic organs defend cells and are especially concentrated in the organs where lymphatic tissue is located. They're separated from surrounding organs by connective tissue capsules. Examples would be the thymus, the spleen, and all the lymph nodes. Interestingly, one thing about the lymphatic system, it's heavily involved in immunity, and what you have to realize is there's not one spot for it. This system is everywhere and throughout everything, which is highly functional for the complexity and completeness of the system. So lymphatic capillaries, also called terminal lymphatics, they have a thin endothelial sac, loosely overlapped and closed at one end. The gaps between the cells are large enough to allow bacteria and cells to enter the lymphatic capillary. They have an endothelium that creates a valve-like flap that open when the interstitial fluid pressure is high and close it when it's low. So within those vessels, very similar to the other vessels we've explored, it's composed of 3 layers: the tunica interna, which is endothelium and its valves, the tunica media, which is elastic fibers and smooth muscles, and the tunica externa, which is a thin outer layer. And it's coverage into larger and larger vessels. So the collecting vessels, they carry lymph into and out of lymph nodes. There are 6 lymphatic trunks that drain the major portions of the body. There are 2 collecting ducts. There's a right lymphatic duct. This is collecting lymph from the right arm and the right side of the head and thorax. It empties into the right subclavian vein. The thoracic duct begins as a prominent sac in the abdomen called the cisterna chyli. It receives lymph from below the diaphragm, the left arm, the left side of the head, neck, and thorax, and empties into the left subclavian vein. So these subclavian veins then function highly in the return of lymph to the circulation. So here is a map of the lymphatic system in comparison and in conjunction with that of the cardiovascular system. So we can see again lymphatic capillaries, lymphatic nodes. We can see the lymphatic trunks and the collecting ducts that lead into those subclavian veins. We can see collecting vessels, and we can understand the lymph flow from the lymphatic capillary as it's climbing back up into the main circulation. Now, the picture here on the right-hand side of your screen, we can see it, the lymphatic system a little bit better. Pretty cool the way it's designed. Cervical lymph nodes that you have, you can see the right lymphatic duct. You can see the thymus gland above the heart. You can see the thoracic duct. You can see the cisterna chyli. You can see the abdominal, intestinal, and mesenteric lymph nodes. We can see popliteal lymph nodes and the lymphatic vessels of the lower limb. We can see inguinal lymph nodes. We can see the spleen, the intestinal trunk, the right and left lumbar trunks, and the axillary nodes. Now, one thing that I want to point out here too, you notice that you have heavy supplies of lymph nodes, usually near openings or where maybe pathogens could enter a little easier. So we're going to talk about the flow of lymph and how that works. Lymph flows under forces similar to those that govern venous return, except there's no pump. So please understand that. Your lymphatic flow is really dependent upon muscle activity because there's nothing to pump it. Lymph flows at low pressure and slower speed than venous blood. It's moved along by rhythmic contractions of lymphatic vessels. So that the walls in those vessels, as they're kind of contracting and moving and being squeezed or squeezing themselves, and like I said, with that muscle movement of surrounding areas, they can get squeezed and lymph can flow better that way. The flow of lymph is aided by the skeletal muscle group. It is aided by arterial pulsation. So the pumping of the blood by the cardiovascular system helps squeeze those lymphatic vessels and pump the lymph. The thoracic pump aids the flow from the abdominal to the thoracic cavity. The valves in the lymphatic system, they prevent the backward flow. Rapidly flowing blood in subclavian veins draws lymph into the systemic circulation. So exercise significantly increases lymphatic return. So lymphoid tissue, it's dense collection of lymphocytes in the mucous membranes and various organs. Diffuse lymphatic tissue is tissue that is a scattered collection of lymphocytes in body passages that open to the exterior. Examples: respiratory, digestive, urinary, and reproductive tracts. Here we have what we call mucosa-associated lymphatic tissue, or MALT. Lymphatic nodules or follicles. Dense masses of lymphocytes and macrophages that congregate in response to pathogens. They are found in lymph nodes, tonsils, small intestine, near the Peyer's patches, and the appendix. So lymphatic organs have well-defined borders. They have a connective tissue capsule that separates the lymphatic tissue from neighboring tissues. The primary lymphatic organs, these are sites where cells become immunocompetent and recognize and respond to antigens. Red bone marrow or beta cells, thymus, those are our T cells. Secondary lymphatic organs, immunocompetent cells that populate these tissues. This would be lymph nodes, tonsils, and spleen. Functions, leukopoiesis, type of leukocyte is dependent on the infection. Remember when we were making blood cells, both red and white, we talked about leukopoiesis. This happens in the red bone marrow, and we went through that picture that's really great about how the differentiation takes place. As a blood cell matures, they enter the sinus and flow away in the bloodstream. The thymus is a bilobed organ in the superior mediastinum between sternum and aortic arch. This houses the developing T lymphocytes. It secretes hormones regulating their activity. They're most active when young, and they're in degeneration or involution with age. So lymph nodes, there are about 450 in a typical young adult. These guys will cleanse your lymph. They are the site of T and B cell activation. They are elongated bean-shaped structures with the hilum. The stroma is the framework of an organ. This is made of reticular fibers and reticular cells. Has a fibrous capsule which encloses each node, and trabeculae which divide the interior into compartments. The parenchyma is the functional part of an organ divided into the cortex and medulla. It has germinal centers. This is the site where B cells multiply and differentiate into plasma cells. Afferent lymphatic vessels carry lymph into the node. Efferent lymphatic vessels, 1 to 3, carry lymph away from the node at the hilum. So similar to our nervous system, we had a similar use of words, afferent and efferent. So here is a great picture of a lymph node. If we take a sagittal section of this guy, we can see what's included in that stroma is the capsule, the reticular tissue, and the trabeculae. And the trabeculae are those little, look like the little walls on the inside of this lymph node. Within the cortex, we have the subcapsular sinus, the lymphatic nodule, the germinal center, and the cortical sinuses. We have the medulla. Within that medulla, we have a medullary sinus and a medullary cord. We can see the afferent lymphatic vessels. We can see the efferent lymphatic vessels. Again, afferent vessels will bring lymph to the node, and the efferent ones will take it away. We can see an artery and venous supply. When we take a little bit more of a microscopic view, we can see the medullary cords. We can see a better detailed look of the medullary sinus. We can see evidence of a macrophage. What the trabeculae look up a little bit more closely, or look like a little bit more closely. Lymphocytes, reticular fibers, and a venule. So we have cervical lymph nodes, which monitor lymph coming from the head and neck. We have axillary lymph nodes, which receive lymph from the upper limb and breast. We have thoracic lymph nodes, which receive lymph from the mediastinum, lungs, and airway. We have abdominal lymph nodes, which monitor lymph from the urinary and reproductive systems. We have an intestinal and mesenteric lymph node, monitors lymph from the digestive tract adjacent to the appendix and intestines. We have inguinal lymph nodes in the groin, and they receive lymph from the entire lower limb. We have popliteal lymph nodes, which receive lymph from the leg. Okay, the tonsils. There are 3 sets located at the entrance to the pharynx to guard against ingested or inhaled pathogens. The palatine tonsils, they are a pair at the posterior margin of the oral cavity, and these guys are most often infected. We have lingual tonsils, which are a pair at the roof of the tongue. At the root of the tongue. We have pharyngeal tonsils or adenoids. It's a single tonsil on the wall of the nasopharynx. So here's a picture so you can get a little bit more acclimated to the location. The pharyngeal tonsil. We can see the palate, the palatine tonsil, and then the lingual tonsil. So when we talk about the spleen, we will hear red pulp, and this is sinuses filled with erythrocytes. And it functions in blood production in the fetus. It's a blood reservoir, and it's an erythrocyte graveyard for RBC disposal. So white pulp is lymphocytes, macrophages surrounding small branches of the splenic artery, and it monitors blood for foreign antigens. So here's an example of where the spleen is located. It's right under the diaphragm on the left-hand side of the human body. It will have a splenic artery and a splenic vein. You can see where it lies in relation to the pancreas and the kidneys. This picture has a really nice inferior vena cava and a representation of the aorta and the common iliac arteries. On the bottom microscopic picture, we can see the red pulp, we can see a central artery, and we can see white pulp. So on the right-hand side of the slide, we get to see the superior portion of the spleen. We get to see the hilum. We get to see the renal area, the splenic vein, and the splenic artery. Okay, so let's look at non-specific resistance within the lymphatic system. So in this section, we're going to identify the body's 3 lines of defense against pathogens. We're going to contrast non-specific resistance with immunity. We're going to describe the defensive functions of each kind of leukocyte. We're going to describe the role of the complement system in resistance and immunity. We're going to describe the process of inflammation and explain what accounts for its cardinal signs. We're going to describe the body's other non-specific defenses. So, pathogens. These are agents capable of producing disease. Infectious organisms, toxic chemicals, and radiation are examples of this. So your first line of defense, those are your external barriers. That's skin and mucous membranes. Your second line of defense, you have several non-specific defense mechanisms. These are leukocytes and macrophages, antimicrobial proteins, immune surveillance, inflammation, and a fever. The third line of defense of the immune system. This defeats a pathogen and leaves the body with a memory of it so it can defeat it faster in the future. This is B and T cell responses. Non-specific resistance guards equally against a broad range of pathogens. It's not dependent on prior exposure to the pathogen. It includes first and second lines of defense, barriers and their secretions, and its non-specific cells and chemical responses. In immunity, it's a specific defense because it results from prior exposure to a pathogen. It's the third line of defense. So cell-mediated and antibody-mediated lines of immunity, okay, which is third line of defense. This again comes from T lymphocytes and B lymphocytes. It usually provides future protection only against that particular pathogen after initial exposure. So the external barriers, let's talk about that. The skin is difficult for microorganisms to enter the body. It has an acid mantle or film of lactic acid that inhibits bacteria. Defensins, which are peptides that kill microbes by creating holes in cell membranes. The mucous membranes, they protect most body openings. Mucus, it physically traps microbes and contains lysozymes. The subepithelial areolar tissue, this is a viscous barrier of hyaluronic acid. It traps microbes if they make it past skin or mucous membranes. So leukocytes, 5 types of leukocytes. There are neutrophils, eosinophils, basophils, monophils, and lymphocytes. These are non-specific and they're in our second line of defense. When we get into, also natural killer cells are included in there, okay, under the lymphocyte category. But the T lymphocytes and B lymphocytes, they are specific to a specific pathogen, and that is third line of defense. So if something makes it through the first 2 layers, then we have a different action from a different level. Neutrophils, these guys wander in connective tissue killing bacteria. Phagocytosis, they use phagocytosis and produce a cloud of bactericide chemicals. They create a killing zone. They do what's called degranulation. Its lysosomes discharge into their tissue fluid. It's a respiratory burst. It's toxic chemicals that are created, H2O2 and HClO. These kill more bacteria with toxic chemicals than phagocytosis. They secrete cytokines to signal other neutrophils. Neutrophilia is an increase from 5,000 to up to 25,000 cells per microliter in a bacterial infection. So when we go into eosinophils, these guys are especially found in the mucous membranes. These guys stand guard against parasites and allergens and other pathogens. These guys will kill tapeworms and roundworms by producing hydrogen peroxide and toxic proteins. They phagocytize antigen, they have phagocytized antigen antibody complexes. They limit the action of histamine and other inflammatory chemicals. So when we see eosinophilia, it's an elevated eosinophil count in an allergy or parasitic infection. Basophils, these secrete chemicals that aid mobility and action of other leukocytes. Leukotrienes, they attract neutrophils and eosinophils. Histamine is a vasodilator which increases blood flow, speeds delivery of leukocytes to the area. And heparin, it inhibits clot formation and promotes leukocyte mobility. Then we have mast cells. They also secrete these substances. It's a type of connective tissue cell that's very similar to basophils. Natural killer cells, large lymphocytes responsible for immune surveillance. They attack and destroy bacteria, transplanted tissue, virally infected cells, and cancer cells. These guys are non-specific. They recognize the enemy or infected cell and they bind to it. They release proteins called perforins. They create a hole in the infected cell's plasma membrane. They secrete granzymes. This is a group of protein-degrading enzymes. And they enter through the pore and degrade enzymes and include apoptosis. So this will help take care of cancer a lot. We've heard about natural killer cells. Again, this is non-specific immunity. Okay, so this shows a little bit more of what happens in the case of that natural killer cell and why they're so important. So if it detects that there's an enemy cell there, the NK cell releases the perforins, which polymerize and form a hole in the enemy cell membrane. Granzymes from the NK cell will enter the porphyrin hole and degrade enemy cell enzymes. So it's gonna like bust up the other cell's proteins. If that cell can't operate because its enzymatic activity has just been depleted, the enemy cell dies by apoptosis. And then it'll have a macrophage ability. The macrophage, or it will be engulfed by a macrophage. So the macrophage engulfs and digests the dying cell. When we talk about monocytes, these emigrate from the blood into the connective tissue and transform into the macrophages. The macrophage system, this is all the body's phagocytic cells except leukocytes. These are wandering macrophages, and they actively seek pathogens in loose connective tissue. Fixed macrophages phagocytize only pathogens that come to them. Microglia in the central nervous system, alveolar macrophages in the lungs, hepatic macrophages in the liver. They phagocytize tissue debris, dead neutrophils, bacteria, and other foreign matter. The antigen-presenting cells, or APCs, they process foreign matter and display fragments to certain T cells, alerting the immune system to the presence of the enemy. Then we have the dendritic cells. They're branched, mobile, antigen-presenting cells found in the epidermis, mucous membranes, and lymphatic organs. They alert the immune system to pathogens that have breached their surface. Then we have reticular cells. These are branched stationary cells that contribute to the stroma of a lymphatic organ, and they act as antigen-presenting cells in the thymus. So antimicrobial proteins, these are proteins that inhibit microbial reproduction and provide short-term, non-specific resistance to pathogenic bacteria and viruses. And we have two families of antimicrobial proteins. They are the interferons and the complement system. Interferons are secreted by cells infected by viruses. These alert neighboring cells and protect them from infection. They bind to surface receptors on neighboring cells. It synthesizes proteins that defend cells. It breaks down viral genes and prevents replication. It activates natural killer cells and macrophages. It destroys infected cells before they release viruses. There's no benefit to the cell that secretes them. I don't think this thing will play. No, it won't. Okay. The complement system is 30 or more globular proteins that circulate in the plasma in inactive form. It's activated by the presence of the pathogen. The activated complement brings about 4 methods of pathogen destruction. It's inflammation, immune clearance, phagocytosis, and cytolysis. So the complement system, there are 3 ways to activate it. Via the classical pathway, which requires the antibody molecule to get started. It needs the antibody already formed for a specific organism, which is part of specific immunity. The antibody binds to the antigen on the surface of the pathogen. It forms an antigen-antibody complex. It changes the antibody's shape. It results in complement proteins attaching to the antibody. It triggers a cascade reaction resulting in inflammation, immune clearance, phagocytosis, and cytolysis. The alternative pathway does not require an antibody. This is non-specific and no prior exposure is needed. The complement protein binds directly to the pathogen. This happens in human tumor cells, viruses, bacteria, and yeast. It triggers the cascade reaction resulting in inflammation, immune clearance, and phagocytosis and cytolysis. The lectin pathway, this is lectins are plasma proteins not part of the complement system. They bind to carbohydrates of a microbial cell surface, and it sets off a cascade of complement proteins. They're non-specific with no prior exposure required. Triggers the cascade reaction resulting in inflammation, immune clearance, phagocytosis, and cytolysis. The inflammation stimulates mast cells and basophils to secrete histamine and other inflammatory chemicals. It activates and attracts neutrophils and macrophages, and it speeds pathogen destruction. In immune clearance, red blood cells bind with antigen-antibody complexes. RBCs circulate through the liver and spleen. The macrophages of those organs strip off and destroy the antigen-antibody complexes, leaving the RBCs unharmed. This is the principal means of clearing foreign antigens from the bloodstream. In phagocytosis, this assists the macrophages by opsonization. It coats a microbial cell and serves as a binding site for phagocyte attachment. It makes the foreign cell easier to catch. In cytolysis, this is the complement protein that binds to the enemy cell. It will attract more complement proteins. The membrane attack complex forms. It forms a hole in the target cell. The electrolytes leak out. Water flows in rapidly and the cell ruptures. So here is a map of the different pathways. We have the classical pathway, the alternative pathway, and the lectin pathway. So we will let that up for self-inspection on your part if this picture helps you understand what we just went through a little bit better. Okay, so here's an example of the membrane attack complex. Complement proteins form a ring in the plasma membrane of the target cell, causing cytolysis. Okay, inflammation. This is a local defensive response to tissue injury. It limits the spread of pathogen, then destroys them. It removes debris from damaged tissue and initiates tissue repair. There are 4 cardinal signs of inflammation: heat or hyperemia, redness, that's hyperemia, and extravasated RBCs, sorry, I'm not gonna say that word right, edema, which is increased capillary fluid filtration, and pain, which is injury to the nerves, pressure on the nerves from edema, or stimulation of pain receptors, inflammatory chemicals. Also, we can include with inflammation, there's also a loss of function. The 3 major processes of inflammation: mobilization of the body defenses, containment and destruction of pathogens, tissue cleanup and repair. So in the mobilization of the defenses, we have vasoactive chemicals. So for that local vasodilation, it could be histamine and other cytokines that are secreted by basophils, mast cells, cells damaged by trauma, toxins, or organisms triggering inflammation. It washes toxins and metabolic waste from the site more rapidly. Get the defensive leukocytes to the site quickly also. So it increases capillary permeability, dilates local blood vessels, and separates endothelial cells. Fluid leukocytes and plasma proteins leave the bloodstream, like complement antibodies and clotting proteins. So in this process, we have margination, in which selectins cause leukocytes to adhere to the blood vessel walls. We have diapedesis or emigration, where leukocytes squeeze between endothelial cells into the tissue space. Extravasated cells and chemicals that have left the bloodstream. So containment and then the destruction of the pathogen. Fibrinogen that filters into tissue fluid clots forms a sticky mesh that walls off microbes. Heparin prevents clotting at the site of injury. Pathogens are in a fluid pocket surrounded by a clot, attacked by antibodies, phagocytes, and other defenses. So monocytes arrive in 8 to 12 hours and become macrophages. They engulf and destroy bacteria, damage host cells, and dead and dying neutrophils. Edema contributes to the tissue cleanup. Swelling actually compresses the veins and promotes lymphatic drainage. Increased heat increases the metabolic rate, speeds up mitosis and tissue repair. A fibrin clot forms a scaffold for tissue reconstruction. Pain limits the use of a body part so it has a chance to rest and heal. So when we talk about a fever is an abnormal elevation of body temperature. It promotes interferon activity. It elevates metabolic rate and accelerates tissue repair. It inhibits reproduction of bacteria and viruses. So a fever definitely has its purpose, and its purpose is healing. The trick with the fever is to make sure that the feedback loop is working properly, which is why I support monitoring fevers and letting them run their course so they can do their work. They do have a purpose. Exogenous pyrogens, these are fever-producing agents from outside sources. This could be glycolipids on bacterial and viral surfaces. Endogenous pyrogens are chemicals like interleukins, interferons that are secreted by neutrophils and macrophages. They stimulate neurons in the anterior hypothalamus to secrete prostaglandin E2, which raises the temperature set point. Okay, here's the stages of a fever from onset, stadium, and effervescence. So you have a hypothalamic thermostat that is reset to a higher set point. There you are floating in your normal body temperature. You come across infection and pyrogen secretion, whether it's from a pathogen or just from inherent tissue damage within the body, okay, which can happen if it comes from an endogenous source of inflammatory processes. So not every fever indicates the presence of a pathogen. Hypothalamic thermostat is reset to a higher point. The onset of the body temperature rises. The stadium is where the body temperature oscillates around the new set point, trying to do what it does with the fever. The infection ends and the set point returns to normal. And then effervescence is when the body temperature does return to normal. So when we talk about immunity, our expected learning outcomes, we're going to define specific immunity. We're going to contrast immune responses, cell-mediated and humoral. We're going to define active and passive immunity, natural and artificial immunity, and give examples based on exposures. We're going to describe the properties of antigens. We're going to describe the function of antigen-presenting cells, including both MHC and 1 and 2 proteins. The immune system is composed of a large population of widely distributed cells that recognize foreign substances and act to neutralize or destroy them. 2 characteristics distinguish immunity from non-specific resistance. Specific immunity directed against a particular pathogen. Memory: when re-exposed to the same pathogen, the body reacts so slowly that there is no notable illness. So forms of immunity and responses. There is cellular or cell-mediated immunity. This involves T lymphocytes directly attack or destroy foreign cells or diseased human cells. This would include viruses and cancer. Humoral or antibody-mediated immunity. This is B lymphocytes differentiated into plasma cells that produce antibodies. Antibodies do not directly destroy a pathogen. Extracellular stages of infection for virus, bacteria, and yeast are included under humoral immunity. So, acquiring immunity, which is exposures. There's natural active immunity. This is the production of one's own antibodies or T cells as a result of infection or natural exposure to an antigen. Artificial active immunity, the production of one's own antibodies or T cells as a result of vaccination against disease. Vaccine consists of dead or attenuated, please make no mistake, attenuated cells are not dead, they are weakened. Pathogens that stimulate the immune response without causing the actual disease. Booster shots are periodic immunizations to stimulate the immune memory to maintain a high level of protection. Natural passive immunity, temporary immunity that results from antibodies produced by another person. A fetus acquires antibodies from their mother through the placenta and the milk. Artificial passive, this is temporary immunity that results from the injection of immune serum or antibodies from another person or animal. This is treatment for snakebite, botulism, rabies, tetanus, and other diseases. Antigens are any molecule that trigger an immune response. The complex molecules are unique to the organism. They can distinguish self cells from foreign cells. Epitopes are antigenetic determinants. These are regions of an antigen molecule that stimulate immune responses. Haptens are molecules too small to be antigenic alone. They combine with host proteins to create unique complexes. The body can recognize as these as foreign and react. Cosmetics, detergents, industrial chemicals, poison ivy, dander, and penicillin are under this category. Okay, we've mentioned antigen-presenting cells quite a few times, so we're going to talk about that. These include dendritic cells, macrophages, reticular cells, and B cells. They function in the binding and phagocytosis of antigen and foreign cells. They alert the immune system to the presence of a foreign antigen. And under this, they display epitopes on the MHC2 proteins to the T cells in the nearest lymph node. The T cells inspect APCs for displayed antigens. If APC displays a non-self antigen, the T cell initiates an immune attack. T cells respond to two classes of MHC proteins. MHC1 protein occur on every nucleated cell in the body. Cell identification tags that label the cell as belonging to you. They're structurally unique to the individual except for identical twins. Normal self-antigens that do not elicit a T cell response. They are virally infected or cancerous cells. They have MHC1 proteins that will activate a T cell response. These will be destroyed before they can do further harm. T-C cells respond only to the MHC1 proteins. MHC2 proteins occur only on APCs. These are dendritic cells, macrophages, reticular cells, and B cells. They display only foreign antigens. The TH cells respond only to MHC2 proteins. They coordinate both T cells and B cell antibodies for attack. So here's a picture. You can follow the train. This is the action of the APC cell, so you can see it in a little bit more detail with a graphic to help understand it. Okay, in cellular immunity, we're going to talk about the list of the types of T lymphocytes involved in cellular immunity and describe their function. We'll describe the process of T cell activation. We'll describe how T cells destroy enemy cells, and we'll explain the role of memory cells in cellular immunity. So T cells directly attack or destroy diseased or foreign cells. They migrate from red bone marrow to the thymus. They develop surface antigen receptors, but they do not react to the self, but recognize and react to foreign antigens. Immunocompetent if a T cell passes both tests. A naive T cell leaves the thymus and colonizes lymphatic tissues and organs everywhere in the body. After activation by a foreign antigen specific to its receptors, the T cell will clone itself. The immune system then remembers the antigens and prevents them from causing disease in the future. There are 4 classes of T cells. These are the cytotoxic T cells, or TC. These are killer T cells, and they include T8, CD8, or CD8+, and they carry out attacks on enemy cells. We also have helper T cells, or TH cells. These include T4, CD4, and CD4+. These help promote the TC cell and B cell action and coordinate nonspecific resistance. We have memory T cells, or TM cells. These are responsible for memory and cellular immunity. We have regulatory T or TR cells, or what we call Tregs, and they limit immune response. In T cell activation, it begins when the TC or TH cell binds to MHCP, displaying an epitope that the T cell is programmed to recognize. An activated T cell undergoes repeated mitosis. This gives rise to a clone of identical T cells programmed against the same epitope. Some cells become helper T or TH cells to coordinate the attack. Some cells become cytotoxic T cells to carry out the attack, and other cells become memory T cells to remember the antigen. So here is a little map of how that T cell activation takes place. We first have antigen recognition, co-stimulation, clonal selection, and then the lethal hit. So helper T cells are necessary for most immune responses. They play a central role in coordinating both cellular and humoral immunity and nonspecific resistance. When helper T cells recognize the AG-MHCP complex, it secretes interleukins that exert three effects. It attracts neutrophils and natural killer cells. It attracts macrophages, which stimulate their phagocytic activity and inhibit them from leaving the area, and stimulate T and B cell mitosis and maturation. So here is another little map of how you can understand for yourself how the cell attack happens. It starts with that macrophage, B cell or other antigen presenting cell. Then we have the helper T cell, which depending on what the need is will depend on its path that it takes. So if macrophage activating factor and other cytokines are present, it will lead to macrophage activity, leukocyte chemotaxis, and inflammation. And this is the non-specific defense. When this guy gets activated with interleukin-2 and other cytokines, clonal selection of B cells is produced, and this happens in humoral immunity. When that helper T cell is activated by the interleukin-1 and other cytokines, the clonal selection of cytotoxic C cells will take place, and this is cellular immunity. So cytotoxic T cells are the only T cells that directly attack other cells. When TC cell recognizes a complex of antigen and MHC1 protein on a diseased or foreign cell, it docks on that cell and releases toxic chemicals. This is perforin and granzymes, same as the natural killer cells. Interferons will inhibit viral replication. They will recruit and activate macrophages. Tumor necrosis factor, or TNF. This aids in macrophage activation and kills cancer cells. So this is an example of a cytotoxic T cell binding to a cancer cell. So memory T cells, these guys can live for decades. Fewer steps to be activated, and they respond more rapidly than the initial response. The T cell recall response, this is upon re-exposure to the same pathogen later in life, the memory cells launch a quick attack so that no noticeable illness occurs. The person is immune to the disease. So in humoral immunity, we'll go into this. We'll explain how B cells recognize and respond to an antigen. We'll describe the structure, types, and actions of antibodies. We'll explain the mechanism of memory and humoral immunity, and we'll compare and contrast cellular and humoral immunity. Humoral immunity is a more indirect method of defense than cellular immunity. B lymphocytes of humoral immunity produce antibodies that bind to antigens and tag them for destruction by other means. It works in 3 stages, like cellular immunity, recognition, attack, and memory. The B lymphocytes, or the B cells, develop in the red bone marrow. The B cell selection, this is presented self-antigens and foreign antigens. It must not react to the self, but recognize and react to foreign antigens. Self-tolerant B cells synthesize antigen surface receptors. They divide rapidly and produce immunocompetent clones. They leave bone marrow and colonize the same lymphatic tissues and organs as T cells. Activation begins when an antigen binds to these receptors. The B cell processes or digests the antigen and displays an epitope on MHC2 proteins. Once the B cells have processed an antigen, the helper T cell binds to the AG-MHCP complex. The bound TH cell secretes interleukins that activate the B cell. This triggers clonal selection. B cell mitosis gives rise to identical B cells programmed against the same antigen. Most differentiate into plasma cells. They secrete antibodies at a rate of 2,000 molecules per second during their lifespan of 4 to 5 days. Antibodies travel through the body in the blood or body fluids. Some B cells differentiate into memory cells. So this little picture gives you the map of the humoral response system and how that all takes place. Okay, the structure of the antibody. Immunoglobulin, or Ig, it's an antibody that is a defensive gamma globulin found in the blood plasma, tissue fluids, body secretions, and some WBC membranes. It has a variable region. This gives the antibody its uniqueness. It has an antigen binding site, which attaches to the epitope of an antigen molecule. And it has a constant region, which determines the class of the antibody. For example, if it's IgM, IgA, IgE. So antibodies are classed according to the structure of their C region. An IgA antibody is found in mucus, saliva, tears, milk, intestinal secretions. This prevents adherence to the epithelia and underlying tissues. It provides passive immunity to newborns. IgD, this is B cell transmembrane antigen receptor. It's thought to function in B cell activation by antigens. IgE, transmembrane protein on basophils and mast cells. It stimulates the release of histamine and other chemical mediators of inflammation and allergy. It attracts eosinophils to parasitic infections. It produces immediate hypersensitivity reactions. So we're just going to continue. There's an IgG antibody. This constitutes 80% of circulating antibodies. This crosses the placenta to the fetus. It's secreted in secondary immune response and complement formation. IgM is found in the plasma and lymph and is secreted in primary immune response, agglutination, and complement fixation. So let's talk about the antibody attack. Neutralization. The antibodies mask pathogenic region of the antigen. It reduces pathogenicity of the antigen. In complement fixation, the antigen binds to the antibody, changes its shape, exposing the complement binding site. The binding complement leads to inflammation, phagocytosis, immune clearance, or cytolysis. The primary defense against foreign cells, bacteria, and mismatched RBCs is complement fixation. Agglutination. The antibody has multiple binding sites. It binds to multiple enemy cells, immobilizing them from spreading. Precipitation. This is binding antigens, which creates antigen-antibody complex that precipitates and it's phagocytized by eosinophils. Okay, in B cell memory, we have the primary immune response, the immune reaction brought about by the first exposure to the antigen. The appearance of antibodies is delayed for 3 to 6 days. Naive B cells multiply and differentiate into plasma cells. The plasma cells produce antibodies. The antibody titer, as the level in the blood plasma, will rise. Some of the clones become memory B cells. In that secondary response, if they're re-exposed to the same antigen, the plasma cells form within hours from B memory cells. An antibody titer rises sharply and peaks in a few days during this response. Antigen has little chance to exert a noticeable effect. No illness results. The IgG remain elevated for weeks to years. Memory does not last as long in humoral immunity as in cellular immunity. All right, let's talk immune system disorders. We'll distinguish between the 4 classes of immune hypersensitivity and give an example of each. We'll explain the cause of anaphylaxis and distinguish local anaphylaxis from anaphylactic shock. We'll state some reasons immune self-tolerance may fail and give examples of the resulting disease. We'll describe the pathology and SCIDS and AIDS. Okay, so immune response may be too vigorous, too weak, misdirected against the wrong targets. So what is classified as a hypersensitivity response? It's an excessive immune reaction against antigens that most people tolerate. This will include autoimmunity. It's an abnormal reaction to one's own tissues. This is also inclusive of allergies. It's a reaction to environmental antigens. dust, mold, pollen, vaccines, bee and wasp venom, poison ivy and other plants, foods such as nuts, milk, eggs, and shellfish, drugs such as penicillin, tetracycline, and insulin. There are 4 kinds based on the type of response and their method of attack on the antigen. A hypersensitivity, that's type 1 or acute and immediate, is very rapid response. It includes most common allergies, food allergies, and asthma. It's an IgE-mediated reaction that begins within seconds. Anaphylaxis is immediate, severe type 1 reaction. Local anaphylaxis can be relieved with antihistamine. Anaphylactic shock is severe, widespread, acute hypersensitivity characterized by bronchoconstriction, dyspnea, widespread vasodilation, circulatory shock, and sometimes death. Antihistamines are inadequate by themselves. Epinephrine relieves the symptoms by dilating bronchioles, increasing cardiac output, and restoring blood pressure. Type 2, antibody-dependent cytotoxic response. This is IgG or IgM, attacks antigens bound to cell surfaces. This leads to complement activation. Macrophages phagocytize and destroy opsonized platelets, erythrocytes, or other cells. Examples are blood transfusion reaction and some drug reactions. Type 3, this is IgG or IgM, form an antibody-antigen complex and precipitate beneath the endothelium of blood vessels and other tissues. At the site, it activates complement and triggers intense inflammation. Examples, autoimmune diseases, acute glomerulonephritis, and systemic lupus erythematosus. Type 4 is a delayed. This is a cell-mediated reaction in which the signs appear 12 to 72 hours after the exposure. T cells could secrete interferon and cytokines that activate cytotoxic T cells and macrophages. They result in a mixture of non-specific and immune responses. Examples of this could be cosmetics, poison ivy, graft rejection, TB test, beta cell destruction that causes type 1 diabetes mellitus. So when we talk about autoimmune diseases, this is where the immune system fails to distinguish self-antigens from foreign ones. It produces autoantibodies that attack the body's own tissues. It has cross-reactivity. Some antibodies against foreign antigens react to similar self-antigens. Rheumatic fever can be an example. Streptococcus antibodies also react with heart valves. Changes in the structure of the self-antigen. Viruses and drugs may change the structure of self-antigens. Self-reactive T cells, not all are eliminated in the thymus. Immune deficiency diseases. Immune system fails to react vigorously enough. Severe combined immunodeficiency disease, SCID. It's a hereditary lack of T and B cells. It's vulnerability to opportunistic infections and must live in protective enclosures. Okay, acquired immunodeficiency syndrome or AIDS caused by the infection of HIV. It invades helper T cells, macrophages, and dendritic cells by tricking them into internalizing the viruses by receptor-mediated endocytosis. By restoring Th cells, HIV strikes at the central coordinating agent, nonspecific defense, humoral immunity, and cellular immunity. Has an incubation period that ranges from several months to 12 years. So signs and symptoms, early symptoms, flu-like symptoms of chills and fever. Progresses to night sweats, fatigue, headache, extreme weight loss, and lymphadenitis. Normal TH count is 600 to 1200 cells per microliter of blood, but in AIDS it's less than 200. This person is susceptible to other opportunistic infections. Just saying that through all of these are considered immune compromises, okay, whether it's autoimmune or a deficiency or because even though they're on two ends of the same spectrum, it's still a compromised immune system doing something different. And the viruses, those tricky little buggers, they have an ability to I think co-infections are more prominent than anyone gives credit for, especially in a viral situation. You have the virus suppressing things and kind of, has the body busy, and then you can very easily contract bacterial and or fungal infections just as easily. Okay, metastatic cancer. This is when cancer cells break free from the original tumor. They travel to other sites and establish new tumors. Often they enter the lymphatic vessels. They can lodge in the first lymph node. They multiply and destroy the node. It's swollen, firm, and usually painless, but it can spread downstream. So breast cancer treatment, we can do lumpectomies and mastectomies, along with removal of nearby axillary nodes. Okay, that is it for lymphatic system, and you guys have a great day.